we as colposcopists has faced many times confusing and frustrated moments. I too had my share, and many times my Swede score never matched histopathology findings. Many times my pap smear report or LBC report never matched my colposcopic findings. But now, as per evidence, it has been found that all this is possible, and colposcopy is a very subjective field and it is a dynamic procedure. I, Dr. Sujata Mittal, today is going to discuss about the latest evidences and how we should improve upon our colposcopy skills. First of all, first and foremost is that lot of budding gynecologists, they ask me whether colposcopy can be used as a screening tool alone. So let me tell you that colposcopy is incomplete without knowing the age, cytology, HPV status, or both of these, or separately. We should know the parity of the patient, whether she has taken prior treatment, and we should know the high risk factors, for example, multiple sexual partners, early sexual behavior, whether patient has taken the oral contraceptives or not, and whether she is having nutritional deficiencies. So colposcopy is decision support and not a standalone test. It has been recognized that there are many cognitive errors we as colposcopists are making while doing the colposcopy. These are not taught, but they are very much responsible for making the mistakes. So what are these biases? One is the anchoring bias, one is reassurance bias, one is fear-driven conservatism and overconfidence in the visual skill. So I will elaborate one by one all these. First and foremost is the anchoring bias. Suppose we are doing colposcopy and we, on the after application of the acetic acid, we find a dense acetowhite lesion and we mentally label it as the worst lesion. So further scanning becomes cursory. So this is called the anchoring bias. This error is anchoring bias. It is not lack of the technical skill. So they say this is one of the most important biases we as colposcopists make, because based on the first impression, we judge the whole cervix. So we should systematically examine the whole cervix even if we find the worst lesion. Then comes the reassurance bias. There is a high grade lesion, or pap smear says, or LBC says that high grade lesion is there. But we are doing colposcopy and we find the normal looking cervix. So our findings, as I just now told, that many times it has happened. So they are saying this, but patient is having the risk factors and there's a pap smear which suggests HSIL and we are finding normal cervix. Even then we have to take the biopsy and we should not reassure ourselves and the patient that everything is okay. Then there is a fear-driven conservatism among the gynecologists. Definitely, we are very much afraid of overtreatment. There is anxiety about excising CIN that might regress. We have got excessive concern about future fertility or obstetric outcomes. Then there is fear of complications like bleeding, infection, cervical stenosis, and definitely we are very much afraid of the medico-legal complications. And in such circumstances, we ask the patient to come after six months or 1 year. So what does the evidence says? That it is very dangerous because cancer progression is time dependent. CIN3 and early invasive cancer are often subtle, endocervical, and poorly acetowhite. So the latest evidence is that most of the low-grade, high-grade lesions, they are associated with the poorly acetowhite grading. So fear-driven conservatism leads to missed CIN2, delayed cancer diagnosis, and false assurance. And ironically, This bias causes greater harm than the over-treatment it tries to avoid. So, the key teaching statement, it says, fear-driven conservatism converts uncertainty into delay, and delay is the enemy of cervical cancer prevention. So globally, if we want to eradicate cervical cancer, we need to overcome our fear. Then overconfidence in the visual skill. As we get older in doing the colposcopy, we think we are very, very good masters of visual inspection after application of the acetic acid and after applications of the Lugol's iodine. But with a better understanding of the natural history and the biology of CIN and cervical cancer, it is understood that there are many hidden caveats which need to be put into attention.